we get into the nitty-gritty of ketamine-assisted therapy with Dr. Kyle Greenway.
Welcome to the Carlat Psychiatry Podcast, keeping psychiatry honest since 2003.
I'm Chris Aiken, the editor-in-chief of the Carlat Psychiatry Report.
And I'm Kelly Newsom, a psychiatric NP and a dedicated reader of every issue.
The last two episodes of this podcast might have left a bad taste in your mouth about psychedelic-assisted therapy. If that's the case, we've got some mouthwash. In our June-July issue, we featured an interview with Kyle Greenway, who runs a ketamine-assisted therapy center at McGill University. And I promise this episode is going to be more boring than our forays into MDMA therapy in a good way. There's no therapeutic touch, no spirit animals, and no shadow shelves in this work. Dr. Greenway takes a straightforward approach that addresses some of the common problems we all encounter when our patients go to get ketamine. First, there is no end in sight. Ketamine works quickly, but it doesn't last, which means many patients end up on chronic maintenance ketamine therapy. The longer they take it, the less it seems to work, and the harder it is to stop. Dr. Greenway prepares patients with an end date in sight. Next is that therapy is not optional in his approach. In Dr. Greenway's Montreal Model, ketamine is there to reduce the symptoms so the patient can start active therapy, which is where the lasting changes occur. He does not start ketamine until the patient is fully on board with all this, which means they've formed a therapeutic alliance and they're starting to make behavioral change in their own lives. Like a dangling carrot, ketamine is started after the patient begins their behavioral change. Finally, benzos are cut. Around 50% of patients with treatment-resistant depression take a benzodiazepine. We know that chronic benzo use is not therapeutic. Yes, acute use might reduce depression, but chronic use is associated with possible greater depression. So what is the sense of adding another class of controlled substances on top of that? Besides the unsightly polypharmacy, there are also empiric reasons to stop benzos before ketamine therapy. Ketamine works through glutamate, and GABA agonists like benzos, and for that matter, Z-hypnotics, interact with glutamate in complex ways that might blunt ketamine's effects. That's the theory, and several studies have found that ketamine is less effective for depression when benzos are on board, particularly if they're in high doses. So Dr. Greenway tells patients that they're going to need to taper their benzo off before starting ketamine, and he has found that ketamine is an excellent replacement for benzos, treating the withdrawal, effectively washing out withdrawal symptoms. In an open-label case series that he published, there was no worsening of depression, anxiety, or even sleep with this approach as patients stopped their benzo and started the ketamine. Dr. Greenway's approach is called the Montreal Model, and unlike some psychedelic therapies, he isn't trying to liberate consciousness, save the environment, or bring about world peace. As a starting place, he just wants his patients to get out of bed. He begins with that basic behavioral approach, behavioral activation, and blends it into a more acceptance and commitment, mindfulness-based approach in the therapy. We're going to go into an interview now where he describes all the nitty-gritty of what he does, but I'll warn you, you might get more out of this interview if you read the online interview first. That's where he goes through the basics. This is where he goes through the more advanced stuff of what he actually does in the ketamine therapy sessions. Just a note that throughout this interview, we're talking about ketamine and the FDA-approved S-ketamine, Spravato, basically interchangeably in that you can use these techniques with both treatments. However, there is some thinking that ketamine might be more likely to provoke a psychedelic, mind-altering kind of response because it peaks at a higher dose in the brain than S-ketamine.
You know what? I think maybe the question that is increasingly on people's mind is, how to talk about it with patients.
Yeah, tell us about that.
Okay. So, I think at this stage in the ketamine literature, I think it's important to acknowledge that depending on the patient or the provider, the website, you name it, you might see ketamine described as basically a drug that mimics psychosis and or a drug that produces dissociative symptoms and or, a life-changing psychedelic drug. And all of these, I think there's elements of truth in all three of these narratives. And the trouble or the challenge in communicating clearly with somebody about what they might expect before a ketamine experience is to not find yourself at odds with them regarding different viewpoints that might seem contradictory, not setting expectations too high in one direction or the other. So, for example, if people believe that one dose of ketamine will rewire their brains or give them a mystical experience that'll keep them well for the next 10 years, these are the kind of expectations that should probably be softened with a little more talk about, in some ways the ketamine experiences can be confusing and disorienting and maybe not meaningful to some people. And vice versa, I think it's very important not to pathologize people's experiences when talking to them about what ketamine might produce. So I would strongly advise against telling patients that ketamine is clearly a dissociative. You'll experience kind of these semi-meaningless, bizarre symptoms that will, if you're lucky, just fade very quickly. I think that's not a good way to set the stage for patients starting out in a ketamine treatment process, because it kind of reinforces, in my mind, a negative tendency in psychiatrists sometimes to pathologize people's day-to-day lives, people's understanding of their own symptoms or their own emotions, etc.
You're pathologizing dissociation if you do that.
Yeah, exactly. And, even putting the word dissociation so clearly on the experience, I think is a mistake.
What word do you use?
I always make sure to use several words so that I'm not giving somebody, not leading them too far in one direction or the other. So I will often say, for example, that the first name proposed for ketamine is dreaming, and that I think that description actually covers a lot of the phenomena very well. People do report very vivid experiences often. And like with dreams, I think it's very important not to take the content too seriously or too literally. I think the process of experiencing the dreams, and I think one can find meaning in the content, but, if somebody had a dream, and this is a real story, that they should become a nurse, I wouldn't say that is the truth for you, quit what you're doing and go pursue nursing studies. But I would say, that's an opportunity to explore, like, what is it about a nurse? What does that nurse represent for you that might sound appealing? So I like the word dreaming. I think also dissociation fits a little bit the feeling of being disconnected from one's body. Disembodiment is another word from the literature that's used to describe this. And, I think it's okay to tell people also that they might have a lot of emotional experiences, or they might find their emotions are turned down for a while. They might experience something that's described as mystical, dissolving into the universe, for example, but they might not at all. So I try to give people a few different ideas of what the varieties of the ketamine experience could be, so that they're not really coming in with a fixed idea that might not fit their actual experience.
What did you mean when you said the word for ketamine is dreaming? Is there some history there I'm not aware of?
Yeah, this is the very first study of ketamine by Edward Domino. He reported this decades later that it inspired, and the scientists who saw ketamine's effects in humans for the first time, it inspired the label dreaming before any other label was given to ketamine.
Okay. Self-transcendence, does that fit?
Yeah, and that's the interesting thing about ketamine, is that in certain models or in certain contexts, certainly people do report transcendent or mystical experiences.
I've seen studies where it turns down rumination.
It really is kind of a chameleon, because then obviously at high doses, it definitely produces a state of, anesthesia. But at the same time, actually, there are ketamine psychedelic therapists who use very high doses and describe that state as transpersonal rather than anesthetic.
And now for the CME quiz for this episode. Earn CME through the link in the show notes. Which medication or class of medications does Dr. Greenway recommend discontinuing before starting ketamine therapy? A. GABAergic medications. B. Stimulants. C. Antidepressants. D. Lamotrigine.
Because we are based on a model where ketamine is not the treatment in and of itself, ketamine for us is mostly a drug that we're hoping will reduce symptoms, increase engagement in psychotherapy, and maybe deliver some what we might call psychedelic benefits of understanding one's mind better or having powerful experiences. And so in this model, in what we call the Montreal Model, most classically we've given 6 doses in a month, and that's it for ketamine for at least 6 months. And, in that 6 months follow-up, it's not ketamine that we hope will keep people well. It's the behavioral work that we've done before the treatment process really even began. It's the psychotherapy that we've kind of kickstarted that people will stay in if they need it. And, ketamine is compatible with a whole range of conventional medications. And so people are usually, the people that we treat are very resistant generally. So they're usually on at least one, if not other psychiatric medications, which we hope will maintain response.
Is the therapy weekly after the treatment?
This is one where we're very pragmatic. We ask patients to have at least 1 hour of some kind of psychological support during our ketamine 4 weeks of active ketamine dosing. Some will continue for a short period, at least 2 weeks we ask, but some will continue for a month, some will continue for a year. Some patients require a social worker or a case manager, daily in their lives for a long time before they're able to kind of build some momentum.
So can you clarify what is the minimum number of sessions that would be reasonable for your approach?
It's at least 2 weeks before, the 4 weeks during the active treatment, and then 2 weeks after. So eight weeks. The ketamine doses might be twice a week, once a week. But we just ask people to have, a regular conventional 1 hour a week psychotherapy.
Are there guides present during all of the dosing sessions or just the first?
We always have at least one person present in our dosing sessions. I know that's not the model that a lot of clinics use, and certainly not the model that's done with esketamine. But in our hands, we thought about for our randomized control trial on music, we thought about leaving patients alone in the non-music group. And in our population, we didn't feel that was safe, let alone therapeutic. We've seen many people have really, frightening experiences.
And you've not actually worked with esketamine in this psychotherapy, so we don't know if it would work there. No, we haven't worked with esketamine directly. My understanding of esketamine is the pharmacokinetics, because it's intranasal, mean that you can't dose it as high as racemic ketamine. So it's because it would have a long tail. If you gave people the equivalent of 0.5 milligrams a kilogram intravenous, they would be still under the effects and feeling kind of woozy for probably 5-6 hours. You don't get as much of a peak. So my understanding is you may not have as much of a psychedelic or dissociative experience with it.
That's what the studies show. When they administer, even the most classic dissociative scale, you have certainly less of an experience with even the highest dose of esketamine than you would with, 0.5 milligrams a kilogram IV racemic ketamine. I know there are people that are working with using higher doses of esketamine than has been approved by the FDA to try to engender a more psychedelic or even dissociative experience. But in general, I think my view of esketamine is probably the reason why it comes across in the studies overall as being less effective is because it's essentially a lower dose.
That's what people have told me who use both of them. Yeah.
Oh, good. Okay, I'm glad to hear that, because I think from the pharmacokinetics, this is what one would logically conclude.
Yes. By the way, are there any medications, psychiatric meds, that you can't give while giving ketamine?
Great question. There are probably no absolute contraindications, but the one that I think is most accepted to be worth holding, or at least considering stopping, would be GABA agonists or modulators like benzos and Zen drugs.
Why is that?
Well, the pharmacology of ketamine is complex. It is simultaneously a drug that's thought to produce a surge of glutamate, but also block glutamatergic receptors. And so, the GABA glutamate cycle in the brain is, these are some of the most the highest quantity of neurotransmitters in the brain is GABA and glutamate, and they interact in complex ways. So it's possible that, a benzodiazepine blunts the glutamate surge that we believe that ketamine produces. That's one possibility. I mean, there's also evidence suggesting that benzodiazepines reduce the acute effects, the psychological or the subjective effects of ketamine. And in anesthesia, for example, they commonly use Valium or other benzodiazepines to kind of prevent ketamine dreams. So if one believes that the ketamine experience is in itself therapeutic, that's another reason why benzodiazepines might be counter-therapeutic. And the third reason I would suggest in general to consider stopping benzodiazepines in somebody receiving ketamine for treatment-resistant depression, and this is a bit controversial, but in my read of the evidence, benzodiazepines have good evidence for an acute episode of depression while you're starting an antidepressant. But if someone is in an episode that's lasted 5 or 10 years, benzodiazepines are probably, if anything, contributing to the chronicity of that episode.
It's a large study last year found that 50% of people with TRD were on a benzo. This was in France.
Yeah, I missed that study, but I'm happy to hear that because we published an article in Neuropsychopharmacology about stopping benzodiazepines with patients starting ketamine. And that is exactly the number that we found. I think it was 45%.
I had read about lamotrigine might interfere with either the positive or negative effects. Is there an interaction there?
It's, again, lamotrigine, a receptor argument that can be made as a glutamate modulator. But the evidence, I think, is really sparse.
Really the benzos we want to taper them off of.
Exactly.
How do you taper people off benzos while they're undergoing ketamine?
The conventional wisdom is if you had somebody with depression and they are on chronic benzodiazepines, conventional wisdom is to treat the depression first, and then when they've remitted, maybe slowly decrease the benzodiazepines. And, the rationale there would be, you destabilize someone by stopping a benzodiazepine, even if you do it carefully. With the ketamine process, this is what we published, and I believe it has a strong kind of psychological and chemical rationale. The ketamine process itself is an excellent occasion to try to get people off their benzodiazepines. When patients arrive, they've heard about ketamine. If they're going to go forward, inevitably they're probably excited about the ketamine process. And you can say to them, to maximize your chances that this will work for you, we should taper your benzodiazepines such that, the last dose is a couple nights before your first dose of ketamine. And what we showed in our article and what we see clinically is that, there is definitely not a worsening of depression, anxiety, or even sleep in almost everybody, despite stopping benzodiazepines like this, because ketamine is such a powerful treatment itself.
There might be some worsening for a week or a few days before, but just a brief period.
Yeah, exactly. You might see a worsening as you're doing your taper. Basically, because ketamine seems to also be an effective treatment of status epilepticus and benzodiazepine dependence in medical settings, there's a rationale that perhaps it is treating the glutamatergic excess that is caused by stopping a benzodiazepine.
Greenway is an assistant professor of psychiatry at McGill University and director of the Ketamine-assisted therapy program at Jewish General Hospital in Montreal, Canada. You can find his full review in our online edition for June 2024.
Join us next week for part 2 of Ketamine-assisted therapy with Dr. Greenway.
The Carlat Podcast team is now on video. Find monthly episodes of Carlat Psychiatry News on the Carlat YouTube channel or under webinars on the Carlat page.
Send us your feedback and questions of all things psychiatric to asktheeditor@thecarlatreport.com.
Thanks for watching. Hit subscribe if you enjoyed this content. And to earn CMEs for listening, head on over to thecarlatreport.com/podcast.